We are the country with the largest number of premature babies who are born and who survive, almost double that of China. The number is 3.5 million. And the problem that's changing in the past 2 decades is the fact that these premature babies are surviving in the rural areas. And the incidence of ROP in rural Karnataka at least is as much, if not higher, than those reported in the urban centers. To take care of this, there are very few ROP specialists, almost all of them in the bigger cities. So what happens to the unmonitored, unscreened, untreated babies from the rural areas? So this is the extrapolated data that every 2 hours somewhere in this country, 3 babies need treatment. To take care of this, to actually try to challenge this situation, a few years ago we started the Karnataka Internet Assisted Diagnosis for ROP program, which basically looked at trying to replace the ROP specialist with a technician who is able to capture the images of these babies in the rural centers and also make the diagnosis there itself, and of course back up this information or using a robust tele platform. It is so therefore telemedicine, training of ophthalmologists, because eventually we want all the peripheral ophthalmologists to take care of their own programs, and then taking together or talking to the pediatric community and the gynecologists. The requirements are fairly simple. You need the camera, you need a vehicle, you need a team, and you need the laser unit if you're going to provide for the treatment in the peripheral area. I'm going to focus on these aspects. The transport in different zones in Karnataka, we've been using either a regular SUV or a government-provided tempo traveler. It doesn't matter what you use as long as you can strap the camera to one of the seats so that even if the roads are bad, it doesn't show poorly. The enrollment strategy that we have employed has been published. Basically, every single baby weighed in our country, as soon as you figure out that this child weighs less than 2,000 grams, a nurse fills out this card and the lower portion has the mother's name, the contact number and the date of birth. A project manager collects these cards at the end of the week and then schedules appointments for these babies to come to the closest center. Now, the part that's given to the mother has explanation that your baby is born less than 2 kilos and can potentially turn blind, and if it's screened on time, it would not happen. The result of this kind of an enrollment program is that you get feeding centers. If you go to hospital A, B, C, D, E, F, around hospital A, we'll keep referring babies to you. So we've run the costs. It costs less than 5 rupees to enroll a baby, and this includes 2 phone calls, few SMSs, and the printing cost of the card. So it's really low cost enrollment of babies who would have otherwise not come into an ROP program. The training of the team who takes care of these images in the peripheral areas is extremely germane to our program. We published it last year. There are certain key members who have key roles. The project manager is the one who schedules appointments. Is almost got a part-time course in counseling. He's well aware on how to talk to these mothers to make sure they come back for a follow-up, because as you would agree, that's very important. As far as the technicians are concerned, as soon as they take a picture, they have to decide whether this baby needs treatment, needs follow-up, or is completely normal. So that's the green, orange, and the red. The details are not important, but obviously it follows the ETROP guidelines and the new ICROP classification. So green means the vessels have reached the ora serrata, orange means some disease or avascular retina, and obviously the ETROP guidelines or some high risk factor is the red. A very, very busy slide, but I just want to let you know that we have stages of how we do the training. We have basically a level 1, 2, and 3 levels of technicians. They spend 30, 60, or 90 working days with us. On an average, they do about 1,000 exams per month. And at the end, they are pretty good at not only taking these images, but running the whole program. So including the triaging, using the tele platform, communicating with the mother, and even some troubleshooting. Examples of what level 1 and level 3 technicians would do. A level 1, a lesser trained, 30 working days, his attempt at getting the ora serrata, fairly good. But you'd agree here there's a much better picture of the ora serrata. So why is this important? Obviously, if you image the ora and you see the vessels reaching the ora, you can declare this baby fit for discharge. You don't need to see this baby again. Here is a stage 2 and a more subtler stage 1. So the more difficult the diagnosis, the easier the level 3 technician would get it. That's what we're trying to show here. Aggressive posterior ROP and stage 2 with plus disease. So stage 2 with plus disease needs treatment, but if that has to be called red, you need that certain amount of clinical or here imaging acumen. The teams, I just want to give an example of what happens in our rural areas. This would be rural Gulbarga. So there's a district hospital. This is the team that's working there. The babies are screened on the bed in the NICU. The images are reported. There's a project manager who's uploading these images as it happens. And of course, a very germane part is the counseling. We are using images, and someone, Dr. Parijat mentioned how RedCam images can be used to counsel parents. We couldn't help agree more. Here is trying to use an opportunistic time where mothers are sitting with their babies waiting to get dilated. So we talk to them about various aspects, not just about ROP and follow-up, but including with our community medicine professors. We talk about breastfeeding, well baby clinic, immunization, and so on. Training, as I mentioned, what the technicians and the doctors learn at our center is first to work on a mannequin, then with supervision, and eventually they do it on their own. A few of the innovations we've been trying is the fact that we're trying to integrate telemedicine platforms with image analysis platforms. So here we are trying to report the image at the same time having a conversation with the family. So even though the doctor is sitting in the city, the fact that he's talking to the mother or the father, assuring them that we are having a look at your baby's images even though we are not right there, helps them believe in the system and come back for follow-up. The IT aspects, obviously we want a lossless transfer. We are a little lucky that the RedCam images are not very heavy sized images. At best they're a few hundred MB and they're not several GB. So it's easier to transport in terms of saving it and sharing it on a cloud. Since 2009, we have the ability to look at these images on the smartphone. In that same paper, we compared the sensitivity specificity of looking at these images and the accuracy of making the diagnosis on the smartphone, compared it to what expert would do on the RedCam monitor itself, and it's very, very highly correlated, as you can see there. To summarize the tele aspects, you have a peripheral camera, a server, an expert looking at it, and it goes back. The funding model is two types in our center. Either our hospital takes care of it in 2 zones or is a government partnership in 2 others. We do all government patients and all below poverty patients completely free, and we charge only corporate patients. In fact, only 24% of our patients actually end up paying the full charge. With the very specific roles when we work with the government, we have to train, read, and of course advocacy, and the government would give the money for the equipment and the logistics itself. The business model of this has been published in Business Journal. The outcome, more than return on investment, I'd like to deal with it in the amount of blindness it has prevented. Obviously, these names don't mean anything to you, but these are district headquarters. It's important to know that on a fixed day, fixed hospitals are visited. So that's how 89 hospitals get covered in 4 zones, and 4 teams are working on this. Our story started with 3 hospitals in Bangalore and is now about 89. We have now 5 RedCam shuttles, as I mentioned, 2 supported by the government and 3 by the institute. Very recently, we crossed the 55,000 mark. About 1,200 odd babies have been treated, and there are other states who we've had the honor and privilege of training, many of whom shared their experiences in the instruction course on the first day. We compared our system with the more recently published EROP, which is also a similar a technician-based system where they are trying non-physicians to make the report. We found that there was no delay in our system. The delay was about 8 to 10 minutes, whereas in the American system, reports came sometimes 2 weeks after the image was taken, just because of the process they followed. Of course, in the United States, this is an alternate way of doing screening. In our system, it's probably the only way, because otherwise these babies would not get screened. And we also talked about accredited technicians. The blind person years that it has saved can be calculated by the number of babies you have prevented from going blind and multiplying that by the average life expectancy and their per capita income. And you'd agree this is only going to go higher as we progress as a nation. It's about 350 odd crores of blindness saved for an investment of 3 crores. This is a 100-fold increase in the amount of investment for the return. And so when you're talking about scalability, and many members you see on the podium here are also members of the task force, and the National Task Force for ROP is looking at states where there are hardly any or some only ROP programs that needs expansion. We've submitted this paper, it's under revision, and I just want to summarize the final finding. For every dollar spent, $193 of blindness can be prevented using a telemedicine platform, even though the initial costs are high because of the outreach and because of the outcome. This is my last slide. And for those of us who've been in the ROP business, the best part is our patients can never thank us. But when they grow up and they see this beautiful world and you understand that you are a small part of their journey, then that's the thanks that we all wish for. I'd like to invite you all to see our KidRop Facebook page and our website, kidrop.org. Thank you.